problems and issues of health with Dr. Alcena. For this segment of this show, I'm going to continue to talk about liver diseases as it relates to cirrhosis of the liver. Last time when I left off, I was talking about some of the treatment, how we start the process of treating people who have cirrhosis of the liver. To give you an overview, worldwide there are 500 million folks with cirrhosis of the liver. In this country, there are 5.5 million folks with cirrhosis of the liver, and we lose about 25,000 people every year die from cirrhosis of the liver. And worldwide, of course, several million folks die, several hundred million folks die because of cirrhosis of the liver every year. Now, when I was talking about the different steps that we have to take as it relates to treatment, I had already finished with the evaluation, the biopsy, etc. I told you about all the complicating problems that can occur, etc. Now, part of the treatment, of course, has to do with the stage of the disease we're dealing with. First of all, what's the cause of the disease? If it is hepatitis, naturally we have to determine which hepatitis it is. Hepatitis A does not cause chronic liver disease, but it could be B, it could be C, it could be D, it could be E. The most common, of course, is B, followed by C, etc. Then, of course, nowadays there are multiple medications on the market that are available to treat hepatitis C in this country and worldwide. The problem is they cost hundreds of thousands of dollars in some instances, and very few people can afford them. And it is a battle to get the HMOs, of course, to approve, to pay for these things. So that's the problem. That's the problem right there. Then, of course, that would be the first step if one were to be diagnosed with hepatitis C, of course, is to try to, you do the viral load, you do the titer, or not the titer, but you do the genetic evaluation to find out which type it is. There are different subgroup hepatitis C from A1, from 1 to actually 6 different subgroups. And each one of these subgroups have different prognosis. So that's very important to know as well. Now that you know these things, then your patient agree to accept the treatment. Of course, if he or she can afford it, or the insurance company will pay for it, you will try to provide the treatment. Before you do that, of course, you do the viral load, you have your liver function test, you have your blood count, etc. Because these treatments can also affect the liver function test. They can further affect the blood count, etc. So that's one way. If it is alcohol that's causing the problem, of course, you have to try to get the patient into alcohol treatment to try to get them to stop. Very few people can stop abusing alcohol on their own. It's very few people can go cold turkey. It's a very difficult process because alcohol is a serious medical problem with psychological component attached to it. It's not that easy. You have to get some professional help to try to get people into AA and other such groups to try to get them to stop drinking, because if you're treating them and yet they continue to drink, the liver is feeling the toxicity of the alcohol all the time. And that's really washing your hands and wipe it on the ground. It doesn't make any sense. So that's one way. Now, a very important component of the treatment is, of course, diet. Diet is very important because you want to make sure the patient is eating a diet that's not too rich in protein. As I talked about last week, the effect of protein on the liver. When one eats protein, it has to go to the large bowel to be broken down, and then part of it enters into the ammonia pathway right here in the large bowel, and that the ammonia part, then the ammonia then go back to the liver, where the liver has to break it down, process it into amino acid, etc. Ammonia, of course, is very toxic. The higher the level of the ammonia, the sicker the liver is, the sicker the person is. So it's very, very important that one also keeps the patient on a diet that is very low in salt, low in protein, low in salt, and also low in simple carbohydrate, because simple carbohydrate leads to obesity. But before I proceed, I brought with me this book that I just wrote. I wanted to share it with the public before I forget. The Art and Practice of Medicine. The Art and Practice of Clinical Modern Medicine, which is really a big book. It's about 10 pounds. It's 886 pages. Took me years to write it. Took me more than 6 months just to edit it. I edit all my books myself, and I have been editing books for other folks for many years as well. So get your hand on this. If it is medicine you want to know about, if it had to do anything having to do with clinical medicine throughout this country, throughout the world, in the most up-to-date fashion, you're likely to find it in this book. If you're a clinician, students, nurses, social worker, health administrators of one kind or another, the public, of course, I write the book in a way so that it's very easily understood so that the public can understand what I'm talking about. What's the sense of writing stuff if it is so complicated people can't comprehend it? This is not this book. Okay, this is the biggest book I've ever done. This is what, book number 23 or 24 that I've written. I'm sure this book can be found subsequently in your local public library. It just came out this week, and I'm sure you know where to find books. I'm not in the book selling business. You know where to put your hands on book, wherever books are sold online, etc. It's a huge book, 886 pages, 136 chapters. It covers everything having to do with modern clinical medicine, the art that it is. Okay, so take a look at it. Now, important component of the diet, of course, as I say, to keep the person from consuming too much simple carbohydrate as well, because that then can lead to obesity. As you know, obesity is also a very common cause of liver disease itself. So, because if the person is getting, the liver is already sick, and you're consuming large quantities of simple carbohydrate, what you're doing in effect, because the simple carbohydrates goes into making fat. Okay, that's how fat develops. Either you eat the fat yourself, or when you drink stuff that has too much sugar, you eat stuff that has too much sugar, it goes into the liver, it gets processed, and some of it you use for energy, the rest of it turns into fat, and then the fat gets distributed through the soft tissues of the body, and if the amount of fat is too much, the rest stays in the liver, and as it sits in the liver, it damages the liver, because the liver reads it as a foreign substance, as it were, and it reacts against it. You have beginning of an inflammatory process, which ultimately become, we call that fatty liver. But fatty, you can't be an obese individual and don't suffer from fatty liver. And then once you suffer from fatty liver, then you are at risk of developing cirrhosis of the liver. Simple as that. So then, of course, the patient is taking a whole host of other medication for heart disease or kidney disease or lung disease or gastrointestinal disease, etc. All these things ultimately have to pass through the liver. So you have to be very careful how you dose these things so that they don't get the liver into more trouble. Because if the liver cannot handle them, then the situation is going to be worse. So the dosing of different medication is crucial, in particular because most of these things go through the liver that we prescribe for people, that either stuff you take over the counter or stuff that are prescribed by physicians. Ultimately, it has to go to the liver. Okay, so that's a major consideration. So that is very important in the treatment. Also, as you are evaluating the treatment of the patient, you want to take a close look at the liver function test, namely the serum albumin, the total protein, the bilirubin, very, very important, the total bilirubin in particular, and the SGOT, SGPT, very important, because these are part of the abnormality that you're trying to correct. So you're trying to correct if you can. You may not be able to, but you're trying to correct those things. So your treatment is tailored in a way so to try to use this test to improve the situation. But the key test, believe it or not, and there's all this stuff, happens to be the prothrombin time. Because all the coagulation factors, except one, are produced by the liver. The liver is a huge factory that produces a lot of stuff. But we use the prothrombin time as a key test that tells us how sick the liver is, how sick the liver is not. Okay, so that's very important to us. Very, very important. And again, the same situation happens again. We're talking about the blood count. Very important to know what the blood count is. What is the hematocrit? What is the white blood cell count? Because the white blood cell count is likely to be low in someone who has cirrhosis of the liver with secondary portal hypertension. Because if you have portal hypertension, then your white blood cell count is likely to be low. So the lower the white blood cell count, the sicker the person is. So that then increases the risk of infection even more so. The fact that the liver is cirrhotic itself, predisposing the person to frequent infection, but now that you have leukopenia and neutropenia, which mean low total white blood cell count and low neutrophil that actually you need to attack infectious agent that enters into the body, those are low. Okay, so you may want to give the patient a Neupogen, which is a white blood cell stimulator to stimulate the production of white blood cell. But that is transient. If it is critically low, you do that, but doesn't have a lasting effect. So, and it's happened to be extremely expensive, this particular Neupogen. The same thing applies. Somebody has low red blood cell count, inevitable, they're going to have low red blood cell count because they have cirrhosis of the liver. Not only because they may have bled or they are still slowly bleeding from the varices and that develops here, because that's used frequently what happened. They have esophageal varices because of the elevated portal pressure. The liver has this blockage of the circulation inside the liver, so the body is trying to create new vessels. Cannot do that inside the liver because there's too much scarring, so it goes right here, develop right here in the junction where the esophagus is entering into the stomach. And we call those varices, and they are very superficial. And because they're very superficial, they bleed very easily, very easily. Sometimes profuse bleeding, but most of the time it's chronic, slow bleeding. Okay, so that's one thing. The fact that a person has cirrhosis of the liver, this is the liver right here, also causes the iron level to be very high. Now here's the deal. How do you have high iron, which is secondary hemochromatosis, at the same time has anemia? Well, you have anemia because first of all, you have the iron deficiency anemia that can develop, yeah, but you also have the total iron in the liver is high. So what's going on here? Well, what you have here, you have a multifactorial types of anemia. You have blood loss anemia in association with iron deficiency anemia. So, but how can you have iron deficiency anemia at the same time you have too much iron? Well, it's not really iron deficiency, it's a functional iron deficiency. What do I mean by that? Well, you have the iron, but you can't use it. Can't use it. But you say, well, how can you not use the iron? It's there to be used. You cannot use it because of the inflammation. In order for you to use the iron that we eat, or the iron finds its way in the body through some illness or whatever, the iron that we eat goes to the stomach right here, and there is a protein called ferroportin that's located in the wall of the stomach. That's the protein that allows us to absorb iron. And this particular protein, ferroportin, is under the control of another protein called hepcidin. Hepcidin is produced by the liver. Now, hepcidin has complete control over the action of ferroportin. Okay? The lower the level of hepcidin, the higher the activity of the ferroportin, therefore you over-absorb iron. Okay? By the way, this is the reason why people who doesn't have hereditary hemochromatosis, or who doesn't, because there's several genes that can cause that now, up to 4 separate genes. It used to be thought there's one gene, there are 4 separate genes now that has been discovered since, and published in 2003. Now, that's where the problem is. The people who have deficiency of hepcidin has iron overabsorption leading to secondary hemochromatosis, which used to be called years ago, improperly so, iron overload syndrome, Africa iron overload, which is totally bogus, didn't exist. Of course, this science that I'm explaining to you didn't exist then either, but now we know that's exactly what's going on. So what happens here is that you have the infection in a chronic state that's going on. So you have anemia of inflammatory disease. It's not, we were taught, and we're still using the term, and I find myself using it sometimes as well, anemia of chronic diseases. There's no such thing. It's basically anemia of inflammatory diseases, because it is the inflammation that is preventing the body from taking the iron to the bone marrow so as to be able to produce new red blood cell. You say, well, what's going on here? Well, what's going on here, there's a protein we have, all of us have, called transferrin. Okay? The transferrins have attached to it receptors. The receptors are like finger-like thing that is attached to the transferrin protein. Their role is to grab the iron and carry it through the circulation into the bone marrow to incorporate it into early erythrocyte for us to produce red blood cell. Okay? That's how it works. Problem is that because of the inflammation, there is a blockage that is preventing the transferrin protein from doing its job. The transferrin protein cannot properly take the iron and take it into the bone marrow. Cannot do it. So there's a block right there. Because there's a block, so the inflammation is what's causing the block. So what you have, therefore, you have a functional iron deficiency. Okay, you have plenty of iron in the body, but you cannot use it because the transferrin protein cannot do the job. Absolutely cannot do it. So therefore, you have iron that backs up, and the iron it backs up in the liver. Okay, the iron it backs up in the liver because wherever there's chronic inflammation, there's going to be chronic accumulation of iron. And that's a second reason for the anemia. Okay, all right. You have the blood loss that's taking place intermittently from the varices. You have the blood, you have the inflammation that's preventing the transferrin protein from doing its job. Yes. Then you have another problem. You have hemolysis. Well, you see, where is the hemolysis coming from? Well, hemolysis is coming from the portal hypertension. When you have portal hypertension, the spleen becomes enlarged. That's why the backflow of the portal pressure causes enlargement of the spleen. Once the spleen becomes enlarged, you develop a condition called hypersplenism. The hypersplenism is going to cause your platelet to be low, your white blood cell to be low, and your red blood cell to be low by causing them to hemolyze. Okay? So this is the third reason why you have the anemia. So it's a multifactorial reason for the anemia. You say, well, how do you deal with that? Well, it is very difficult, as you can well imagine. You can't take the spleen out. Can't. I'm not a surgeon. I leave that decision to the surgeon. From what I remember in training and medical school, if you take that spleen out, the portal pressure is going to boof, whatever. But again, that's for the surgeon to decide. I don't want to get involved with stuff that I don't know anything about. Suffice it to say, it's a problem. It's a big problem. The sicker the liver, the more cirrhotic the liver, the higher the portal pressure. The higher the portal pressure, the more you have these three abnormalities occurring. Okay, I gave you an idea before that you could transiently treat the individual with Neupogen to try to raise the white blood cell count. Yes, you could do that. Nothing wrong with that. Very expensive. You could also do something else. There's a product that is produced in our kidneys called erythropoietin. Erythropoietin is the hormone that is needed to stimulate the production of red blood cell in all of us, all human beings. Okay? Now, it is made by the kidney. But the last many years, we have been able to make it the scientific community have been able to make it in the laboratory, creating a substance called epogen or procreate, okay, which is a man-made version of the erythropoietin. Again, very expensive. So we could use that to force the transferrin protein to carry the iron from the liver, or wherever it is, another part of the body where it's piling up, to go to the bone marrow to produce red cell. You say, well, how do you do that? Well, that's the interesting thing. Once you use the procreate or the epogen, whichever one you choose, it forces, remember I told you there was a block. There's a block to the left side here is where the transferrin protein is located, can't cross, this is the blockage right here, can't cross the right here. So once you use the procreate forces the transferrin protein over the threshold that's causing the problem, and then that then free it to grab onto the iron and take it to the bone marrow. How neat that is, okay? It's very neat, and you're doing two things. You're decreasing the level of the iron, while at the same time raising the red blood cell count. How about that? In fact, this treatment is being used in people, for instance, who have rheumatoid arthritis, who are going to have joint replacement. We know they're going to have joint replacement 2 months down the road. Okay, what do? Because they're anemic, because of the inflammatory process. Rheumatoid arthritis is an inflammatory disease. What do? Well, we give them procreate to raise the red blood cell count. Then that enables us to take them to the blood bank, take a unit of blood away from them, put it in the blood bank, so if they need blood transfusion during the surgery, they can use their own blood as opposed to using somebody else's blood that's been given to them. And this has been going on for years. This is nothing new. I'm just giving to you as an example. What I just told you about the liver, that's being done all over the world as well and all over the country. In fact, it's being done more so in places where they have these liver transplant centers. Okay? There are many studies. One study from Italy, published in the British Journal. There's a study from Europe, from other part of Europe, like in France, and a couple of studies in this country from these major centers that are doing liver transplant with this process of using procreate to remove the iron. Because the iron that's sitting there is very bad. Doesn't matter where the iron is sitting, be it in the liver, be it anywhere else, by definition, it has to degrade. Here it is, you already have a sick liver that has nothing to do with the iron. The liver is already cirrhotic, it's still a chronic inflammation, and you have iron piling up in it because of the inflammation that's causing that. As the iron sits there, by necessity, it must degrade. As the iron is degrading, it's releasing free radicals. And the free radical is very toxic to human tissue. So that's another terrible thing that's happening to the liver because of the release of the free radicals. These are classic medical, clinical stuff that's going on that I'm telling you about. It's all in this big book. The chapters there on cirrhosis of the liver, chapters on hemochromatosis. You could read all this stuff. This book is about 10 pounds. It's a huge book. 886 something pages this book has. Okay, so all this stuff that I'm telling you are being done all over the world, all over in major centers to try to help. So that's the anemic part of it, which is very important. Very important, because the person is anemic because of the liver problem. They're very tired all the time. They're weak. The heart is suffering because the heart is overpumping in an attempt to carry oxygen to the rest of the body. That stress out the heart. And if they have other complicating factors such as hypertension, if it is obesity that's causing it, obesity is highly associated with hypertension. If it is alcoholism that's causing it, alcoholism is highly associated with hypertension. So you have a second problem now that's taxing the heart. And the anemia is taxing the heart because the lower the red blood cell count, the harder and the faster the heart has to pump in order to be able to distribute sufficient oxygen to the rest of the body, to perfuse the different organs in the body, the brain, the eye, the kidney, the lungs, you just name it, okay? The skin, which happens to be the largest organ in the body, etc. So that's another problem. And then, of course, we talk about the brain. Okay, the lower the red blood cell count, the more taxing it is for the brain as well. Headaches, dizziness, strokes, all these things are occurring because the person is chronically anemic. That's what the cirrhosis will do to you. It causes severe anemia that then can affect all sorts of other stuff. The kidney can get seriously affected by the effect of the anemia, because if you can't perfuse the kidney properly, then the kidney function becomes abnormal. Then you have problem right there, because you're going to start developing renal insufficiency, which you really don't need in this setting, because you already have so much problem. You're only going to wind up, you already have secondary hyperaldosteronism, which is aldosterone is produced by the kidney, and because the liver cannot handle it, the level of it is secreting in a high quantity in the bloodstream, and you have secondary hyperaldosteronism with salt retention that's causing you to have ascites, and now you have kidney disease on top of that. How are you going to remove the fluid from the body if the kidney cannot urinate it out? I mean, I can go on and tell you how these things are all interconnected. In any event, I'm going to stop here. Next week, I'll continue to talk more about the treatment of cirrhosis of the liver. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.